Welcome to MD Conversation. It is our sincere hope that this program will enhance the discussions between you and your physician regarding your condition. This program is not meant to replace these discussions with your doctor, but simply to make them more meaningful. The material in this presentation is independently produced. The mention of any medical product or drug does not imply its endorsement. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendations. This module reviews advanced treatments for OAB. Other modules are available which discuss other aspects of overactive bladder. Each module is relatively short. However, in total, there is quite a bit of material. It is recommended that you take your time viewing one module at a time, and not try to take in too much at once. You are welcome to view each presentation as many times as you like. Furthermore, you may pause the presentation or skip through parts of it using the player on your left, and you may view the slides in any order you wish. The term overactive bladder, or OAB, describes a group of bothersome bladder symptoms, which include frequent urination, nighttime urination, urgency to urinate, and leakage episodes, or incontinence, related to poor control of bladder urgency. Now, let's look at some of the treatment options available for overactive bladder. We can divide these treatments into three broad categories: conservative measures, including behavioral therapy and physical therapy, medications, and advanced treatments such as surgery. This module goes into some detail about some of these more advanced treatments for the minority of patients who fail on medications and conservative measures. Not every new treatment is mentioned here, and not all treatments are available at all centers. Patients are carefully selected for consideration of these treatments. Most failures of medical treatment can be dealt with by adjusting the medical therapy, rather than pursuing more aggressive measures. Let us review some relevant anatomy of the bladder. This figure shows that the bladder is composed of a strong muscle and an inner lining of special cells. When we urinate, urine passes through the urethra, or urine passage. The urethra is surrounded by a valve muscle, or urethral sphincter, which helps to hold urine in the bladder when it is being stored. There are many possible causes of overactive bladder. Most people have what is referred to as primary overactive bladder. This means that for some unknown reason, the bladder undergoes changes which cause it to escape the normal control that we have over it. The bladder muscle spasms, or contracts, causing a sudden sense of urgency and frequent urination. If the contraction cannot be suppressed in time, leakage, or incontinence results. Conservative and drug treatment are aimed at either abolishing the abnormal contractions of the bladder muscle directly, or strengthening the pelvic floor or sphincter muscle to prevent leakage and suppress the bladder contractions secondarily. When behavioral therapy and medications fail to relieve the symptoms of overactive bladder, surgical options may need to be considered. Surgery for OAB ranges from minimally invasive techniques to major open surgery, with the latter being reserved for the most difficult cases. Minimally invasive techniques include instilling medications into the bladder, injecting Botox into the bladder muscle, and implanting a bladder pacemaker. Open surgery includes making the bladder bigger or diverting the urine away from the bladder. When drugs taken by mouth fail to relieve symptoms, or the side effects are too severe, then these drugs, or others, can be placed directly into the bladder. To do this, a small tube or catheter is placed into the bladder, and the medication solution is injected into the bladder through the catheter. The patient holds the solution in for a time, then urinates it out. Different drugs have been tried in this way. Oxybutynin, or ditropan, is a commonly used bladder relaxing medication that is normally taken by mouth. This drug can also be dissolved in solution and instilled into the bladder. Amazingly, extracts of red-hot chili peppers, desert cactus, and other related compounds have also been used in this manner. These medications have had variable success, and there have been some technical challenge to overcome in giving drugs this way. For now, this form of therapy is still limited to very few centers, and is usually done as part of a research study. Botulinum toxin, commonly referred to by its trade name Botox, is now beginning to find uses in urology. This toxic compound was first isolated in 1920 and purified in 1946. It acts to block nerve signals at the junction where nerve meets muscle, and in this way it temporarily paralyzes those muscle fibers. Botox was first used in the field of medicine in the 1960s and 70s for the treatment of an eye condition called strabismus. Among other conditions, Botox is now being studied for use in treating overactive bladder symptoms by injecting it directly into the bladder muscle. This is a 15-minute procedure done on an outpatient basis or same-day surgery. Some doctors do this right in their office or in a minor surgery clinic. The procedure can be done with full general anesthesia or with sedation and local freezing jelly in the urine passage. Initial success rates are in the area of 60 to 90%, and the results last on average anywhere from 6 to 9 months. It should be emphasized that Botox in the bladder is presently not an approved use, and there are very few centers presently using Botox in this way. It is also not an insured service in most areas, and it is expensive. There are many forms of neuromodulation, where nerves that can impact urination are stimulated to produce the desired effect. We will describe the most commonly used form of neuromodulation, also referred to as a bladder pacemaker. As suggested, this involves electrical stimulation of nerves in the lower part of the back, called the sacral spine. This electricity alters the nerve reflexes that control urination. Success rates with the bladder pacemaker for overactive bladder range from approximately 50 to 75% over 5 or more years. Neuromodulation involves passing a small needle down into the nerves of the lower spine under local freezing. The needle is then stimulated with electrical impulses until an appropriate response is achieved. A tiny wire is then passed down through the needle and the needle is removed. Initially, the patient wears an external stimulator connected to the wire for a week or so to be sure that the procedure will improve his or her urinary problem. This figure shows how the wire passes down through the skin into an opening in the spine and then sits alongside the nerves of the lower spine. If the test period of stimulation is successful, then a pacemaker device is implanted into the fatty tissue of the upper buttock to provide permanent stimulation. As a last resort, open surgery may be required for difficult-to-control overactive bladder symptoms. Fortunately, with improvements in medical therapy, few patients need this type of surgery. However, for some, it may ultimately be necessary. These techniques are highly effective. The most common major surgery performed for OAB is called a bladder augmentation, where the size of the bladder is made bigger by opening it up and laying in a patch of bowel across the opening. A diversion involves somehow changing the natural flow of urine from the kidneys to the outside of the body. Often, the bladder is left in place, and a piece of bowel is used to connect the bladder to the skin to allow the urine to drain out of the body. In rare cases, the bladder must be removed, and a new bladder or drainage system is made out of a piece of bowel. Let's take a moment to review the main treatment options for overactive bladder. Note that there is a steady progression in the treatment path from the most conservative treatments to the most aggressive. As a general rule, your doctor will move further down this path until all the less aggressive options have been tried. This concludes our presentation. You are welcome to view this presentation as many times as necessary. When you are ready, we encourage you to access these other modules discussing OAB. These resources may help you find further information or support about your condition. This is just a sample of modern references discussing overactive bladder, available at your local medical library. We hope that this program has given you a better understanding of urinary incontinence and overactive bladder. We wish you the best for the future, and thank you once again for using MD Conversation.